Well, welcome to our webinar today. We are so excited to be here with you. My name is Stephanie Braun. I'm the Seattle Clinical Site Manager.
And I'm Amanda Beatty. I'm a registered dietitian.
Today, we are going to be talking about identifying the warning signs of eating disorders, discussing some of the influences that can have an impact on different individuals and their relationship with food. We're also going to touch on some of the eating disorder diagnoses that are in the DSM-5, and we're going to share some things about the different levels of care that we offer. To start off, our new location, which is here in Seattle, we're located on First Hill. We've been here since February, so it's been really exciting to see the growth that's happened. Here at this location, we have two different programs that exist. We have our Eating Recovery Center eating disorder program. We have our partial hospitalization day treatment, and then our intensive outpatient treatment for adults. And then we also have our Insight Behavioral Health treatment, and that is for mood, anxiety, and trauma-related disorders. And at this time, we have our partial hospitalization day treatment and intensive outpatient treatment. We'll talk a little bit more about this later. And we're soon, in July, we're going to be opening up an intensive outpatient treatment for adolescents for our Insight program. So feel free to ask us more questions if things come up, if you have questions about those programs. Let's see here. So throughout our webinar, feel free to type questions in the bottom of the screen. There should be a question and answer section. And then at the end of the webinar, in the last 15 minutes, we'll have a chance to go over your questions at that time. See here. There we go. All right. So eating disorders can affect over 30 million people in the United States alone, which is a staggering number. Eating disorders can impact anyone from any type of background, whether they're socioeconomic background, gender, age, no matter what type of experience they've grown up with. Eating disorders do not discriminate against those things. And so that's really important to remember when you're working with different individuals. Let's see here, hopefully this will pause for us. Okay. Something to think about with that in mind is that most likely at some point in time in your practice, you will have individuals that walk in the door that have either struggled with an eating disorder in the past or are currently struggling with an eating disorder. You will probably also most likely work with someone who has struggled with their relationship with movement. And so those are some things that we're also going to discuss today. A variety of different things bring people into private practice when they walk through your door. Maybe someone is struggling with a traumatic life situation. Maybe they're recognizing they want to see their anxiety or their depression decrease. So there's a number of things that can bring someone in. And a lot of times there is maybe disordered eating that's actually happening, and sometimes it can go undetected. And so those are some of the things that we want to kind of focus on and talk about today, keeping that in mind. Some individuals are aware of their disordered eating patterns, and they might be aware of how movement is impacting their life in a negative way. Other times there are individuals who are maybe completely unaware of those behaviors and how they're using disordered eating to kind of cope with their anxiety. We also see sometimes when individuals are very avoidant and resistant to addressing and naming those behaviors. And oftentimes that's because they're using those behaviors as a way to cope and a way to deal with stress.
Mm-hmm. Yeah. So one thing we really want to emphasize is how important you as community providers are in helping detect and helping diagnose early signs and symptoms of eating disorders. We know that eating disorders often aren't co-occurring or occurring in isolation, but are often co-occurring with other diagnoses. So the research shows us that 33 to 50% of individuals struggling with anorexia and nearly half of individuals with bulimia nervosa, binge eating disorder, and other specified feeding and eating disorder, which is often called FED. We'll talk about that later as well. Are suffering from a comorbid mood disorder such as depression. And we know about half of individuals with anorexia, bulimia, and binge eating disorder are suffering from a comorbid anxiety disorder, such as OCD or a social phobia. Some other common co-occurring diagnoses that we see is PTSD or past trauma history, substance abuse disorder. For those that are in the more medical field, you might see early onset of osteopenia or low bone density, or secondary amenorrhea, which is loss of menstruation. So these are all signs and symptoms that you as community providers will really see first. So you're kind of that first line of defense in helping detect when some eating disorder symptoms might be showing up. This is so important because we know that early intervention leads to better outcomes. Specifically, research on treatment for eating disorder indicates that early intervention and early treatment results in 3 main improvements. That's an improvement in the speed of recovery, so a shorter duration in terms of length of recovery time, reduces the symptoms to a greater degree, and improves the likelihood of staying free of the illness. Pursuing early intervention is also so important to help prevent things like chronic malnutrition and other lifelong health consequences, even death. So if you're a provider listening to this and thinking, wow, okay, how would I even approach someone, or how would I even begin to talk about potential eating disorder behaviors or relationship with exercise with a client or an individual that I'm working with? One thing that we use here for patients in our mood and anxiety program that we suspect might have some disordered eating behavior is a pretty thorough pen and paper eating behavior self-assessment tool. If something like that is not available to you or doesn't feel quite appropriate for the setting that you're working in, then we recommend having just 3 or 4 questions kind of prepared in your mind that you can easily ask an individual to assess where they might be at with eating, body image, and or exercise. So some examples might be to just ask very broadly, hey, can you tell me a little bit about your relationship with food? Or can you tell me a little bit about your relationship with exercise? There can be so much information in the responses to that question. So some warning signs to look for would be someone who's really preoccupied with food and when they're going to get their next meal or what calories are going to be in it. Someone who feels like they must exercise every day, is a very rigid routine around that. And then someone who may say they have some shame or guilt if they aren't able to eat in a certain way or exercise a certain amount of time. Another great question you can ask is to have somebody do a 24-hour food recall, which is a bit more of an objective question if that feels more comfortable. And that's basically just asking, what did you eat yesterday from the time you woke up to the time you went to bed? And again, there's so much information in that kind of response. I would say things to look out for are someone who's able to pull out a food journal of everything they ate and the exact portions and the calories. So a lot of rigidity and control around food, maybe someone who's limiting a certain macronutrient, would be fat, proteins, or carbohydrates. Somebody who is only eating at certain times of the day. Just anything around food and even fluid intake. Often we see individuals excessively drinking water to kind of reduce hunger cues. There's so many hidden things you might find in those responses. And then the third and last example I'll give is asking a more direct question, such as, when is the last time you took non-prescribed laxatives, diet pills, diuretics, or made yourself throw up? This might seem like a bit more of a direct question, a bit more of an aggressive question, if you will, and it is, but also really important to ask if you feel comfortable, because we see so often that eating disorders follow this don't ask, don't tell policy. So an example would be an individual might be using non-prescribed laxatives, and they won't lie about that when asked about it, but they certainly won't offer that information. So sometimes being a little more direct can be really helpful. The last thing I'll say about that is, even if you ask any of these questions or all of these questions and no new information is presented, or you don't feel like there were any warning signs, at a minimum, you've just opened the door for this individual to come back to you in the future as sort of a trusted, safe, non-judgmental place to talk about these things more openly in the future, which is incredibly important. So we hope that this webinar is educational, but also empowers you as community providers to feel a little bit more comfortable to address these things with individuals, because it's so, so important.
So next, we're going to kind of move into talking about some of the main eating disorder diagnoses. We're not going to go very in depth on these, but we're just kind of touch on some of the main ones. Starting off with anorexia nervosa, it's characterized by an obsessive fear of gaining weight, or an obsessive fear around actually being in a healthy body weight range. We often will see severe weight loss for individuals with this diagnosis. A couple things to think about and to recognize is that anorexia has the highest mortality rate of any mental health issue. And 1 in 5 deaths from anorexia are related to suicide. There we go. Some other things to kind of recognize and be aware with this diagnosis are restricting, obviously, caloric intake. Individuals can also end up purging, whether that's through actual vomiting or through excessive exercise. And we're going to talk a little bit more about the excessive exercise piece in a little bit. One of the other things I just want to mention with this is you'll often see hair loss, like Amanda mentioned, secondary amenorrhea, so the loss of menses for women. Bone loss can actually take place, severe constipation, and there can also be cardiac complications. So it's a very serious illness.
Next, we'll touch on bulimia nervosa, which is often just referred to as bulimia. And this is an eating disorder characterized by binging, which is consuming a large amount of food in a short period of time, followed by some form of purging, which is an attempt to eliminate the calories consumed. Purging can be through self-induced vomiting. It can also be through laxative use, diuretics, or overexercise, as Stephanie mentioned. Some signs and symptoms to look for, some warning signs for someone with bulimia would be someone who has a strong preoccupation with weight or body or their changing shape. Another big warning sign behaviorally would be someone who is trying to avoid eating in public settings or trying to avoid eating with friends and family in a social gathering, often because they have planned binges for later or because they want to purge in private. Some physical things to look for in individuals you might be working with would be unusual swelling around the jawline. That could be indicative of self-induced vomiting, or oftentimes they'll have lesions on their hands or just kind of cuts on their knuckles, which is also another sign that they might be vomiting. Another thing would just be overall fluid retention or edema throughout the body. Next, we'll touch on binge eating disorder, which is often referred to as BED. This is a relatively new diagnosis in the latest edition of the DSM-5. I believe it came out in 2013. Binge eating disorder is often confused with bulimia because both are characterized by episodes of binging. However, unlike bulimia, binge eating disorder is not followed by a compensatory mechanism to eliminate calories, like laxatives or purging or excessive exercise that would be seen in bulimia. One thing I also want to highlight about binge eating disorder is that binge eating disorder can be, anyone can be suffering from binge eating disorder, not just those that are overweight or in a larger size bodies, which is a very common misconception. Binge eating disorder does not discriminate based on BMI or body size. So it's really important to have a weight neutral approach when diagnosing someone with binge eating disorder. Behaviorally, things to look for would be someone who's hoarding food or who has a lack of structure or inconsistency around their meal times. That might be indicative of binges occurring. From a physical standpoint, you might see extreme fluctuations in weight, both up and down. And you might also have someone who's complaining of some gastrointestinal issues or new stomach cramps, which also might be indicative of binging.
Next, we're going to talk about ARFID, which is avoidant restrictive food intake disorder. And this disorder can oftentimes actually also get confused with anorexia nervosa because it's characterized by persistent failure to maintain a healthy body weight, or for oftentimes for young children, we'll see a lack of progress in them being able to gain the weight that they're needing to gain. We oftentimes see this in younger individuals, a lot of times with males, but this actual diagnosis can exist for children and for adults. Sometimes individuals maybe who are considered picky eaters as children or adults, it actually might be an undiagnosed eating disorder. Some of the things that we'll see are significant weight loss, again, like failure to gain the weight that they're needing to gain as they grow, significant malnutrition, and so there'll be deficiencies when it comes to their nutrition. Many individuals with ARFID will have symptoms of food avoidance or decreased appetite, abdominal pain, and some have an intense fear of actual vomiting. And there's definitely a connection around the taste, texture, color, flavor of food. And so it might be more of kind of the sensory component of what's going on that's impacting their relationship with food. And something to keep in mind with this disorder is that it also impacts, obviously, their engagement with other people. For example, like someone with ARFID might be really fearful of going to a birthday party because of the reality that there'll be food there, and maybe they're fearful of what that interaction will look like if they're really hesitant to be able to eat that food. So some signs to notice and to recognize with that disorder.
The last one we'll talk about today is OSPD, or Other Specified Feeding and Eating Disorders. And this is sort of a catch-all category for disordered eating that describes individuals who have maladaptive thoughts or behaviors around food, body image, exercise, but do not fit all the criteria for the DSM, all the DSM criteria for the other diagnoses we just talked about: anorexia, bulimia, binge eating disorder, and ARFID. So one example of this is atypical anorexia nervosa. Atypical anorexia is someone who exhibits all the DSM criteria for anorexia, except they are not underweight despite a significant weight loss. This one is so important because I think it's a quite common misconception that you can look at someone and tell based on their weight alone if they have an eating disorder, and specifically anorexia. And that is absolutely not true. An individual can lose a significant amount of weight and still have a normal or above normal BMI. They'll be suffering from anorexia. In this case, they would just have atypical anorexia. So another example where approaching someone with a more weight neutral lens when considering what disordered eating they might have go on, might be having going on is really important. Next, we'll touch on diabulimia. Diabulimia is typically seen with type 1 diabetics, and these individuals will misuse their insulin with the intention to control their weight. So they'll do this primarily in three ways: either by delaying the dosage of the prescribed insulin, by decreasing the amount of insulin they inject, or by completely omitting the insulin as a form of weight control. Some pretty serious health consequences from this are hyperglycemia, or high blood glucose levels, and glucose excretion in the urine, which is essentially them purging glucose through the urine, which is why it's referenced as diabulimia, because they're purging calories to lose weight.
Next, we're going to talk about orthorexia. This is not in the DSM-5, so it's not an official eating disorder diagnosis, and we want to kind of start off with that. It's not a medically recognized term, but it is a term that has been used since 1996. Yeah, 96, I believe. Yeah. And it's a term that is kind of addressing the issue that is around the obsession for health or wellness or extreme wellness. The word actually means thinking about like right eating. So individuals struggling with this disorder are focused more on the purity and the cleanliness of food. I'm sure you've heard the term like eating whole food, really focusing on organic food. And we're going to kind of talk about that a little bit more in a presentation. So some things to recognize with this is that it's not about the quantity of food, but it's about the quality of food for these individuals. And we recognize for a lot of individuals, eating healthfully, as some individuals might think of it, that it can be maybe fine for many individuals, and for others, it can turn into an obsessive focus. And so the main thing to recognize with this is when an individual is actually, their body is not getting the nourishment that they need because of their obsession around health food. Another thing we're going to touch on today is over-exercising and exercise compulsion. And just a couple things to recognize with this is when exercise and movement is to the extreme portion where someone is consistently fixated on needing to move or needing to burn calories or needing to exercise. It doesn't actually have to do with a specific type of exercise, but more just an obsession around needing more movement in their life. And so when they're not participating or acting on movements, their mind is consistently focused on that, fixated on that, and it becomes, for some individuals, it's a compulsive thing that they feel like they can't actually stop. The next thing we're going to touch on is body dysmorphic disorder. And this disorder is characterized by obsessive thoughts around their body image. For some individuals, they're obsessed about their size. Other individuals might be about their specific weight. And this disorder can impact someone from actually any of the disorders, except, so I guess I would say mainly with, not arson, but many of the eating disorder diagnoses that we talked about earlier, this diagnosis can also be apparent in many of those diagnoses. So something to kind of recognize and reflect on is, how is someone perceiving their body? Is it a distorted view? Are they looking in the mirror and actually seeing something different that doesn't actually exist? Next, we're going to talk about the Pacific Northwest culture. And this is kind of a big part of what we wanted to kind of focus on in this conversation, to reflect on the beautiful place that we live in the United States and how amazing the different components of this area, and also to recognize the different cultural perspectives around food and movement that impact all of us, and oftentimes we don't necessarily talk about. So we want to kind of bring this conversation to light, and we know this is an ongoing, an ongoing conversation, but we want to recognize that there are a lot of amazing, beautiful things about the Northwest, and there are a lot of strong perspectives about food and movement that can actually also have a harmful impact on people's health. So with that in mind, there's a lot of different terms that can be thrown around that we're going to just kind of mention, that I also kind of touched on with orthorexia. People maybe have started to recognize that dieting is maybe not a helpful way to exist in the world with food, and yet there's a lot of different lifestyle or wellness perspectives that can actually be just as harmful as many diets. So some of these terms are clean eating, gluten-free, dairy-free, paleo, being vegan or vegetarian, the keto diet. There are so many different perspectives, raw diets, organic diets, and we recognize that out of those different approaches to eating, for many individuals, it actually might be fine and might be a balanced perspective, but for some individuals, it can become, they can become really fixated and obsessive around that eating component, and it actually begins to start to cause malnourishment in the body. And so that's the important thing that we begin to talk about. We recognize that these are popular trends that ebb and flow, and honestly, if you think about every decade, there's new trends that kind of pop up. So another thing to think about, and that we want to begin to have you and challenge you to think about, is your own perspective and emphasis on what is your relationship with food look like, and then also thinking about movement. And again, in the Northwest, we have this beautiful area that we really, a lot of people are kind of focused on living a very active lifestyle, and there's nothing wrong with that, but it's important to recognize when being active can actually start to cause more harm in the body, and when that turns more into an obsession. And so part of what we want to challenge you with today is thinking about what are the ways that you look at food? what are the perspectives and kind of your food philosophy is kind of something that we talk about.
Yeah, definitely. So as Stephanie mentioned, there's often so many individuals will come in and say, oh, I'm on a vegan diet, or I'm doing the Whole30 or a ketogenic diet. And again, that could be a totally balanced thing for their lifestyle, and it can be rooted in some disordered eating or disordered thoughts. And so if you're a provider saying, someone just told me, I'll use vegan as an example, that they're a vegan, how would I even begin to assess whether or not that is the balance or the disordered eating? Like, how can I tell which is which? So one thing we would say is if you have been working with this individual for a long period of time and are sort of more of a long-term provider, then looking for drastic shifts in food behaviors, relationship with body, relationship with exercise, or again, using veganism as an example. If an individual has came into your office and said, oh, I decided to go vegan, has never once mentioned animal ethics or that veganism is something they're passionate about, I would be curious and want to know a little bit more about why they made that shift. And again, it could be for balanced reasons, and it could also be because they're looking for control, or they're looking to have acceptance, or it could be so many other layers actually underneath that, which would be signs of maybe disordered eating. So being curious about any drastic shifts we see. If you're a provider who doesn't see individuals long-term, but maybe just seeing someone one time, so it's a short-term provider, one word that we always think about when trying to assess balance from disordered is the word intention. So what is your intention for wanting to run every single day? What is your intention for wanting to be a vegan? What is your intention? And often the answer to that will really be able to suss out whether the intention is because it's something that really fulfills them, or if it's something, if they're really trying to control something else. Because eating disorders are so often a maladaptive coping mechanism for other emotions or other things going on. Misconception often is that they're about vanity and body image, but really they can also be really great maladaptive coping mechanisms. So another thing we wanted to talk about is the specific language. I know we see organic in our screens, and Stephanie mentioned some other buzzwords we often hear in Pacific Northwest and likely everywhere, like superfoods and junk food, healthy, unhealthy. And then one we hear often too is good foods and bad foods. And I think it's important to highlight the danger of assigning morality to food, good with good and bad language, when food inherently is neither good nor bad. We really practice the philosophy that all food fit, and this means that there is a time and a place and a context for an individual to welcome all foods into their lives. I think that language around food is something also to be listening for, not only with the individuals you're working with, but maybe also a little bit with yourself and how you're thinking about language around food. One other thing I would say about language is we also hear that food is fuel, whether it be for going in the mountains or food is medicine. And absolutely, food can and is nutritional value for our bodies, absolutely. And food can be so much more. It can be social interaction and birthday parties and tradition, culture, memories, gatherings. So I think it's important to recognize that it needs to be a balance of food is nutrition and food is so much more. And when an individual focuses too much on food as nutrition, that's when that rigidity can come into play and some of these more orthorexic tendencies and thoughts can start surfacing. So that balance would be something to keep in mind as well.
Definitely. So as clinicians, part of what we want to challenge you to think about is, when you reflect on your own relationship with food and your relationship with movement, to be aware of how might that impact the lens when you sit with other individuals. Just to be able to acknowledge the different ways that you reflect on those things in your own life. How does that impact what you might perceive or what you might not see with an individual? So just to be able to acknowledge that there is a lens that we approach individuals with. And those things are definitely, they're very real in our life. They're happening for our patients, and we want to be able to discuss that and dialogue about that. This is an ongoing conversation throughout our lives, really, that will continue to evolve and reflect and kind of maybe even change the way that we see food and movement throughout our lives. So we encourage you to continue this conversation with other clinicians, to continue this dialogue in consult groups you're in, and to reflect and recognize like what is coming up for you, what do you notice in your own relationship. So with that being said, Amanda is going to compile our questions, and I'm going to kind of continue to talk a little bit more about our last point for today, and that is thinking about the different levels of care that exist. All right. So we have several different levels of care that we offer at Eating Recovery Center, and they're offered in many different places. And we're going to start with kind of talking about intensive outpatient. So this level of care is kind of our lower level of care. Individuals might come in for this level of care because they're just needing more support. And maybe you have someone in your practice that is just needing a little bit extra support. They're needing a little bit of accountability, but they're actually able to have a lot of self-accountability and being able to, whether it's eating meals on their own, but maybe they're needing to learn a couple skills. And so intensive outpatient is offered 3 to 6 days a week here in Seattle. And so we have kind of a range that individuals can have some flexibility of when they're able to come in. And that's 3 hours a day. And during that time, we're doing skills training. We focus on groups, including dialectical behavioral therapy, acceptance and commitment therapy. And we also integrate kind of a wide range of different skills focusing on body image as well. And so at that level of care, someone, again, might have some symptoms coming up throughout the week and some symptoms maybe during the day, but not to the extent that they're needing kind of a full day treatment. And so there's a lot of flexibility with that level of care. And then our partial hospitalization is 7 days a week, and that's 10 hours a day. And so at that level of care, we're offering coverage through the entire day for support with staff. And so we have 3 meals a day and then a wide range of different groups. Some of the groups that I mentioned earlier, DBT, ACT, and then radically open DBT as well, including body image work. We're focusing on helping them engage with their values in their life so that they can reintegrate back into their life. Individuals at this level of care might be struggling with some level of suicidal ideation or self-harm. And then when someone is needing more support, is when the residential level is more appropriate. And that's 24-hour care. So for individuals who are maybe needing more support, whether it's around meal support, and I think in particular, like someone who's struggling with obsessive exercise, if they're going home in the evening from our PHP and they're not able to kind of follow through with the guidelines we're setting out for them, they're probably needing to step up to a higher level of care. Residential is also important for medical stabilization. So for individuals who are maybe kind of more in an acute place. And then inpatient is also available at our Denver location. And this is for the most acute eating disorder patients that we're working with. So that's kind of the main, we just wanted to touch on those different levels of care to give you an idea of what is available. And again, at the Seattle location, we have our intensive outpatient and our partial hospitalization. And then in our Bellevue location, we have IOP, PHP, and residential.
Wonderful. Yeah. Okay, so we got a lot of wonderful questions. So,
I'll just touch on this real quick. So I just have our information on here for Seattle location. If you have any questions, you can reach out. You can call our front desk office. You can get in touch with either Amanda or myself. And then I included our clinical assessment team. If you have a specific, patient or client in mind that you recognize they're needing a little bit more support, please feel free to reach out to that number, and we would love to be able to help you with that process. So.
Okay, now we will jump to questions.
Yeah.
So I'll just take it from the top, and if we don't get time to get through all of the questions in the remaining time that we have, we'll provide some information at the end about where to email those questions. So question 1, can someone have anorexia nervosa and bulimia nervosa diagnosis at the same time? So I think what I would say with this is individual can have anorexia nervosa at one point in time and then bulimia nervosa at another point in time. Typically, only one diagnosis would exist at a time, but there is an anorexia nervosa subtype, anorexia binge purge subtype, which would encompass someone who's primarily struggling with anorexia, but experiencing some of the binge purge behaviors as a form of weight control as well. That would be something you want to know. I think that's right. Okay. A second question are, what are interventions for ARFID with young kids? So I can speak a little more to the nutrition side of it. Someone with ARFID, some interventions we would do would be to create an ARFID-specific menu. So here in program, we do meals together. Someone with ARFID, we would have a menu for them to choose from that already has their safe foods on there, or foods that they feel are approachable given their given their texture, the consistency, the color, all of those things that they've been trying to avoid. After we get comfortable with eating with them, then we would start doing little exposures. So changing one menu item to be something a little bit more challenging or a little bit new in terms of texture, consistency, whatever it may be that they need to work with. I think ARFID differs a little bit in how we would support them, because we're really looking for even just small gains and exposures rather than huge leaps in welcoming all foods.
Yeah, just one thing I'm thinking about individuals I've worked with in the past, you touched on like the exposure piece, and something that we utilize a group called exposure response prevention, and kind of the ideas behind this are helping someone to cue into what's going on in their body, what's their reaction, what are their fears about, having these exposures and rechecking in with them. And the idea is over time, as they have exposure, they're going to hopefully see a decrease in their internal response, and starting to recognize kind of building new connections in our brain of like, okay, I can do this. I can have a new experience with it, whether it's a food or
Absolutely. There's one really great book. I'm going to read the title for if someone's wanting more information around ARFID. It's called Helping Your Child with Extreme Picky Eating, a step-by-step guide for overcoming selective eating, food aversion, and feeding disorders by Braun and Laughlin. Might be mispronouncing those last names, but that's an excellent resource if you want a more in-depth deep dive into how to approach a young child with ARFID. Okay, the next question is, what is the best way to discuss with clients and their parents recommendations for them to go to a higher level of care for his or her eating disorder? Do we refuse to stop treating them if they don't get help if they are really unwell?
That's a great question. Yeah, and I definitely have a lot of friends that are in private practice that have asked a very similar question. I think the challenge with this is that there's not a right or wrong way. A lot of it kind of depends on your own boundaries and what you feel comfortable with. I would say that sometimes holding that boundary and expressing that if you're not able to get a higher level of care, or you're not willing, at some point in time, it might be actually really important to draw that boundary. Some of the things I've seen with providers in the community is maybe setting up a contract and having some clear direction of, maybe by the end of this many weeks or by the end of the month, here's some steps that we need to see in order for you to stay working in the outpatient level. And if that point in time comes and they're not able to follow through with that, holding that boundary is really important clinically to establish the severity, really how significant this eating disorder is and how much it can be really catastrophic, the impact of it.
Yeah, I would just add that I think it would also be important to ask yourself as an outpatient provider if you can effectively help or support this individual in the work that you're trying to do with them if they do have this eating disorder also co-occurring, and how much more effective that work in the outpatient setting might be after getting a higher level of care treatment. So yeah, I think I would echo kind of having a firm boundary if that's really what you think is the best bet for that individual.
Yeah. One other thing I'll add with that is sometimes our fear is, well, they're just going to not have any help at all. And yet I think when we reflect and kind of help them process through what are the different fears, what are the things that they're afraid of, oftentimes, the layers underneath that we unpack with individuals, like I mentioned earlier in our presentation, is of course they're going to be hesitant to give up this behavior because it's maybe become a way that they've survived. And so for some individuals, the eating disorder has been a survival mechanism. And so of course they're going to be hesitant to maybe just let it go and get treatment. And so helping them process through and I think wrestle with where's their motivation at. And a big part of this is helping them connect with their values, what's really important in the big picture. Because if you help them connect with their values and they recognize they actually want independence and freedom, and yet that eating disorder is kind of taking them away and it's a barrier from them reaching those values, I think that can sometimes be a helpful part of that dialogue.
Last thing I promise we'll move on is,
this is fun.
Yeah, this is a great question. We here, and I know many other facilities also, will work hard to stay in touch with you as outpatient providers as the individual you're working with is going through treatment. So that dialogue will constantly be open. And the goal is to send them back out into the community once they've received the appropriate treatment and these levels of care. So I think sometimes even saying to an individual that this will be temporary, we can still work together when you get back and maintain that relationship throughout is also important. Okay. How do you know when to diagnose body dysmorphia related to body shape and size, considering the symptoms are usually correlated with most other eating disorders?
Yeah, that's a good question. And I think some of the things to think about with body dysmorphic disorder is that it's an extreme kind of approach to try to fix something that they feel like is wrong. And it's a skewed perspective. And so I think that can look like a lot of different things for different individuals. So it can be hard that there's not maybe specific examples of this is happening 3 times a week. But I think in general, the idea is if someone really is having consistently a skewed perspective of their body and a skewed approach to what they're seeing, it would feel appropriate for this, to kind of be another diagnosis. Any other thoughts on that?
No,
Yeah.
Okay. Can you please cite sources for the mortality rate of anorexia nervosa as being the highest mortality rate of all mental health disorders?
So this is located in quite a few different places. I'd say a couple of places that are a great resource that some of our statistics come from, the NEDA website. And I'm trying to think of some of the other ones you would also pull.
Yeah, so it's National Eating Disorder Association. I know the specific is on there. There's also different academies of nutrition and dietetics that have a lot of great information and resources on eating disorders as well. What to say about that one? Can you tell us more about the ethics and appropriate level of care in settings or communities with limited resources?
Yeah, so that is also, I think, something that I've had many individuals over the years ask. A couple of things I guess I would point out. I recognize at Eating Recovery Center, there are some scenarios where Medicaid is actually accepted, and so it depends on the scenario. And so I'd encourage you to reach out to our business office. And then we also encourage people that are in financial need to reach out to our business office because they do offer some levels of financial aid. And so that is probably the best resource. I would say that there are organizations in the community that also offer resources for individuals. For one example, Hope Sparks down in Tacoma has providers that focus on low income and they have professionals that are trained with eating disorders. So there are definitely some resources, and my hope is that over time that will continue to grow.
Absolutely. Yeah, I think calling the business office or the assessment team and they can hook you up with a ton of resources, maybe resources more specific to whichever area the individual is in need of. Okay. For clients who are pre-contemplative or recognizing their mild to moderate eating disorder symptoms for the first time, is there a book that you would recommend for educating such a client? Maybe something funny rather than medical or scary that would help such a client get more insightful.
Actually, yeah, I know. I have all my books sitting here. And I think one book in particular that kind of stands out to me is Life Without Ed. by Jenny Schaefer. She talks about her own story and her journey of wrestling with an eating disorder, and she has other books that she's written since then. But I think it gives a more connected, relational approach to her journey. And for some individuals, I have found many patients have really connected with this book. Another book that I would recommend would be 8 Keys to Recovery from an Eating Disorder. And so there's different steps in here that might help someone recognize, oh, I'm struggling with the same thing, or I have these same patterns going on for me internally. So those would be some of the books I recommend.
Yeah, wonderful. Okay, to clarify, when we identify bulimia and orthorexia in a client, is that considered an OSPED diagnosis? This is a really great question. So we talked about atypical anorexia nervosa and bulimia. Those are officially under that OSPED diagnosis category. Orthorexia, body dysmorphia, and overexercise, those are not technically diagnoses yet.
So no, they're not
in the future. Maybe in the future, but they're not officially DSM diagnoses yet, and they don't technically fall under OSPED quite yet. Okay, we got a few more coming in. We received one comment more so than a question. I think it's important to consider culture when determining rigidity of eating as well. It can be subjective based on different cultures. Absolutely, absolutely. I think it's a great comment. I think with everything being said, it's all within the context of the individual that you're working with. There are absolutely some things that need to be followed with rigidity and precision, culturally based, and even diet-based. If you're working with a diabetic or someone who has celiac, absolutely there should be some rigidity around that. I think, again, it's just more of the context and whether or not their intention for following these things is more rooted in disorder thought.
Yeah, thank you for that comment as well. That's very important to reflect on and think about.
Okay, great. Another question. How do you decide between residential versus inpatient as the appropriate method of treatment?
So I guess the main thing I would say with this is our clinical assessment team has some very specific, they go through an in-depth 2-hour, oftentimes, conversation and asking a lot of specific questions. A lot of times it comes down to the severity of what this person is needing medically for them to be stabilized. And like I mentioned, we don't have inpatient in this city, but our inpatient treatment is located in Denver. And sometimes for individuals who are maybe very much refusing and the family is recognizing they're needing more care, that potentially might be an appropriate time for them to be an inpatient.
Yeah, and I think a big key for inpatient is to be able to provide 24 hours a day, 7 days a week medical stability too. For monitoring heart rate, blood pressure, all those vitals that really do need to be monitored around the clock.
And our residential, obviously, it's 24-hour care, and yet it's a different level of what they're needing. And I'd say, again, kind of back to our clinical assessment team, they're going through really in-depth questions to find out what level is appropriate and needed.
Okay. Should a dietitian be diagnosing a patient for DSM-5? I thought that was only for practitioners who are qualified. Great question. Dietitians should not be making official diagnoses. I think being informed about what potential diagnoses there are in order to help recognize that there might even be something to refer a patient to is really what we're going for. So just being educated on what diagnoses they might be falling under, but not formally making that recommendation. So an example would be if you're working with an individual in an outpatient setting and you're seeing some of these red flags as a dietitian, maybe having them call the assessment team, or after you do a little assessment of your own. One great assessment is called Eating Attitudes Test 26 or EAT 26. And that's just an objective 26 questions that will kind of signal to you whether or not some of these disordered eating patterns are present, and then referring them to someone who can make more formal diagnoses, whether that be calling the clinical assessment team or just a different provider in the area.
Yeah, and I guess one other thought with that is finding out, like, do they see an ARNP? Are they meeting with a psychiatrist? Are they meeting with a therapist in the community, other individuals that can give that diagnosis.
Yeah, absolutely. Okay, maybe one more. We keep getting new ones, so I don't know where to pause. We can do one more. What would be a possible treatment approach for someone with orthorexia?
Yeah, good question. So for many individuals I've worked with who are struggling with orthorexia, because it's not a diagnosis, they're often coming in obviously with other diagnoses. I think part of it is helping them explore and recognize what are their beliefs connected to, where are their beliefs stemming from. There's oftentimes a lot of obsessive compulsive thoughts around their beliefs with food and movement, and kind of unpacking, helping them process like where are their beliefs about movement stemming from, thinking about family connection and family dynamics and family things that they've learned, whether from their family culture, the culture they live in, their friend groups, what are their beliefs. And so that's, in a lot of ways, it's long-term work that they're unpacking that and processing through, and also being able to help them recognize, kind of back to the values piece, is helping them see the impact it's actually having on their physical body, that what they're striving for is health, and that word can mean a lot of different things to different people, but in actuality, it's causing malnourishment. So I think part of it is doing some psychoeducation and also skills training, and helping them kind of dive in a little bit deeper and recognize the pattern and where that's coming from.
I think one thing I would recommend too is having an individual write down in like one day their thoughts or their food rules that they follow around food or fluid or exercise. And sometimes when they see it on paper, how many things are governing or structuring their day around food, and the amount of thought and effort they're putting into prepping and packing and meal planning. I think that can be a really big moment for an individual, and that also kind of gives you then a potential hierarchy to work from in tackling some of these or addressing some of these things. One last thing I want to add is we just got a comment that BDD, body dysmorphia, is in the DSM-5. Thank you so much. The code, if anyone's wondering, is F4522. Thank you. Okay.
And then I want to make sure I have the last page.
Yeah, okay. So
I want to pull up our last page on here. And so if we didn't get to your questions, please feel free to email Alia, and she will pass those on to us as well. There's more information on here about your continuing ed certificate. So be looking in the next week, and you'll be getting an email with the directions and the continuing ed survey and how to access your certificate.
Yeah. And again, apologies if we didn't get to address your questions. Thank you all so much for submitting the questions and attending the webinar. Alia's email address is there, and if you shoot her an email, we can help address those questions there.
There we go.
Yeah. Okay.
All right.
Thanks, everybody.
Thank you.